Hello everybody, my name is Amir Riaz. I'm a PGY2 internal medicine resident over at Cleveland Clinic, Florida. Today I'll be presenting this poster on behalf of my co-authors, and our poster is called Immune Checkpoint Inhibitor Leading to Acute Myocarditis. Immune checkpoint inhibitors have shown positive outcomes in patients with advanced malignancies. However, they are associated with a spectrum of side effects known as immune-related adverse events. These immune-related adverse events can affect a myriad of systems, including the integumentary, the gastrointestinal, hepatic, endocrine, and cardiovascular systems. Although rare, fatal toxicities have been documented, especially when used in combination with other immune checkpoint inhibitors. The onset of these reactions is variable. However, fatal reactions have been reported even after a single treatment of nivolumab and ipilimumab. Myocarditis is actually one of these potential adverse effects. So for our patient, we have a 68-year-old Caucasian man who presented to the hospital initially for dyspnea and troponemia. His past medical history was significant for metastatic bladder cancer, status post BCG treatment, and subsequent chemotherapy and radiation. Unfortunately, he was found to have recurrent metastatic disease. Thus, he was subsequently started on nivolumab. He initially responded well. However, his metastatic burden worsened. Therefore, nivolumab was discontinued, and he was started on a trial with ipilimumab. In terms of the review of systems, he was negative for fevers, chest pain, cough, or palpitations. An electrocardiogram showed normal sinus rhythm without any acute ST segment or T-wave abnormalities. The labs were significant for a troponin level of 0.649. The CK was greater than 5,000. The ALT and AST were elevated. ALT was at 376, AST was at 286. An echo was done and showed mild left ventricular hypertrophy. A cardiac MRI was done as well and showed findings consistent with myocarditis. These findings and the pictures of these findings are located on the lower right side of the poster itself. Ipilimumab was held and he was immediately started on IV methylprednisolone given these findings. He was started at 1 gram daily with significant improvement in symptoms. So for the discussion, checkpoint inhibitors have shown promising results. However, we need to make sure that these medications are used cautiously, and clinicians need to be aware that they do have potential toxicities, as they can be fatal. Immediate recognition improves the prognosis and outcome. However, other life-threatening etiologies should be considered, such as myocardial infarctions, pericardial tamponade, stroke, and cardiac failure. In this case, combined exposure to both the nivolumab and the ipilimumab increased our patient's likelihood of toxicity. Due to the prompt recognition of drug-induced myocarditis, the offending agents were immediately discontinued and methylprednisolone IV was started with improvement. His cardiac biomarkers, liver function test, and CK improved as a result. It is important to keep in mind that cardiac toxicities have been even reported in patients without significant cardiac risk factors. Checkpoint inhibitors have shown promising results, but these agents must be used judiciously as the medical community continues to discover potential adverse events and effects of immunomodulator antibody therapy. So I want to thank you all for listening in today, and I hope you all have a wonderful day.